Good evening, everybody. Thank you for joining us. My name is Melanie Ionase. I'm a physician relations specialist here at Rothman. And tonight's webinar is Dr. Barrett Woods, orthopedic surgeon, spine surgeon, excuse me, topic that he'll be covering tonight: who should have spinal surgery and why, advancements in the treatment of common spinal problems. Dr. Woods' office locations are in Egg Harbor Township and also Washington Township. Just a few quick housekeeping notes. At the bottom of the screen, you will see a Q&A box. Please feel free to ask any questions during the presentation, and we're going to leave some time at the end to get to as many as we can. And if not, feel free to email myself at melanie.ionase@rothmanortho.com. I will leave that in the chat box for information, along with Rothman's 1-800 number. So at this time, I'm going to pass it off to Dr. Woods. Dr. Woods, thank you so much for tonight.
Melanie, thank you very much for setting it up. I think it's very important for us to have these opportunities to sit and talk, provide information. There's a lot of fear about spinal surgery, and I hope that this presentation will shed some light on people that should consider spine surgery and people who should not. There are certain things that spinal surgery does excellent at treating, and there's other things that spinal surgery is not appropriate for, and we're going to discuss those issues tonight. And I hope you guys, if anyone that's listening has questions or concerns, please place those in the Q&A box. We'll do everything we can to address those questions. But without further ado, my name is Barrett Woods. I am a spinal surgeon at the Rothman Institute. I have been here for 7 years now. I am originally from Pittsburgh, Pennsylvania. I did undergraduate training at Clemson University in South Carolina, and then did my medical school training as well as residency in University of Pittsburgh, where I am from. And I did my fellowship at Thomas Jefferson in Philadelphia, and as stated, been in the shore for 7 years and really have been very happy here. My wife is also a provider at Rothman Institute. She does non-operative spine. She does injections and pain management. And we have 3 young sons. And we've been very happy with our transition here. So today, what we're going to talk about is common issues that affect the spine, people that should consider spinal surgery, people that should not. Most of the problems that we have develop because of degeneration of the intervertebral disc. The intervertebral disc is the cushion between the bones, and it serves as a shock absorber. And as we age, that disc degenerates. It loses its ability to suck in water, which serves as the cushion between the bones. As the cushion starts to degenerate, arthritis develops, nerves get compressed, and that's when we consider surgery. The reason the disc degenerates is multifactorial, and there are many reasons why it does occur. We, as scientists, are trying to find ways to stop the degeneration of the disc. Some of the treatments that have been studied include various oral supplements like glucosamine and chondroitin, gene therapy treatments to stop or slow disc degeneration, and even stem cells. And I have a lot of patients that come to me and ask me about stem cells and things of that nature. And what I will say, at this stage of the game, unfortunately, we do not have a proven scientific way to stop the degeneration of the disc. And that is something that we are still attempting to solve. That's a problem that once we figure out, probably many less people will need spine surgery. However, unfortunately, at this stage, we do not have the ability to slow or stop disc degeneration. There are certain factors which accelerate degeneration of the disc, such as obesity, smoking, and things of that nature. And so there are things that you can do to protect your spine. But the fact of the matter, as we get older, the discs degenerate. And unfortunately, some of us develop compression of our nerves, which result in problems that need to be treated surgically. And so disc degeneration is really analogous to a tire. So if you look at a tire, there's an outer ring, there's an inner portion of the tire, which is air. For the disc, it's actually a jelly called nucleus pulposus. That's what sucks in water. And what happens is, as that air dissipates, or the nucleus pulposus starts to dry out, it's like literally driving a tire on a rim. And so as we proceed through life, we start to bend the rim, we start to develop arthritis. And if arthritis compresses nerves in our back or in our neck, that's when we consider an operation. And so this is kind of a histologic example of disc degeneration. You can see a normal disc and a disc that has been dried out. If you look at this picture to my left, on the left is a normal healthy disc, and you can see how bright and shiny that disc is. And on the right is a disc which has undergone disc degeneration. And so what happens is our discs lose the ability to suck in water. When the discs are no longer hydrated, what happens is they can no longer shock absorb. And so you develop arthritis. Arthritis occurs because the bones bump together. And if you develop arthritis that encroaches upon the space for the nerves or pinches nerves, that's when you start to develop pain or weakness in your arms and legs. And that's what this lecture is going to discuss. First, we're going to start with the lumbar spine. So before we get into some of the common problems of the lumbar spine, I think it's important to go over some of the basic anatomy. And one of the things that made me want to become a surgeon was once I was exposed to anatomy, how really cool and incredible the human body is. It's really amazing what God designed. It is incredibly complex, but it's also very simple. We have nerves in our back. Nerves in our back supply strength, sensation, and motor function to our legs. So each nerve in our back supplies a very specific portion of our legs. It's just like turning a light switch on in the kitchen. You turn the kitchen light on, you flip the switch, you expect the light to come on. Same thing with our lumbar spine. Each nerve has a very specific innervation, and it supplies a specific portion of our lower extremities. So this is a lumbar MRI, which shows that the spinal cord is ending in this patient at about L2. And below L2, those are the nerve roots which innervate or supply strength and sensation to our legs. And this is a dermatomal chart. So if you look at this picture, it shows the innervations of the nerves from the back to the leg. So each nerve supplies a very specific portion of the leg. You can see that L1 and L2 nerve roots supply the groin. L3 is more of the anterior thigh. L4, is the anterior thigh over the kneecap to the shin and top of the foot. L5 is kind of the side of the leg. S1 is the back, the thigh, the calf, and the lateral border of the foot. So very commonly, I have patients come in and say, oh, I have sciatica. Sciatica is a very generalized term. Essentially, if you have a pinched nerve, you will have pain in the distribution of the nerve. So that could be in the S1 distribution, which is true sciatica, which is pain going down your butt, back of your thigh into your calf. You could have an L3 nerve root compression, which is not going to cause pain in that same location. It would cause pain in the front of your thigh. L4 nerve root is going to be down your shin to the front of your foot. So when someone presents to me and they have compression of a nerve and is complaining of pain in their leg, the first thing I'm thinking is, where is the nerve root compression? What has to be compressed in order for that patient to have pain in that distribution? And if you have nerve root compression and pain in that distribution of the nerve, that's when we consider doing an operation. And that's something that we're going to discuss a little further as we move forward. So what are the reasons that someone should have spinal surgery? A lot of people come in with tremendous pain in their back, and back pain in and of itself is typically not a good reason to have an operation. That doesn't mean the pain is not real, but there are certain things that spinal surgery is excellent at treating, and that's what we were going to address right now in regards to lumbar spine. So the three things that when I evaluate a patient to determine if I can help them surgically is, do they have compression of a nerve in their back? If a nerve is pinched and they have pain, numbness, or weakness in the distribution of that nerve, that's when we consider doing an operation. So this is a lumbar MRI. This is a patient who has a massive disc herniation at the L4-5 level. You can see the space for the nerves is being occluded. This is a patient that presented in to my office, was having difficulty walking, was having severe leg pain, and couldn't walk. And so that is a very good reason to have surgery. My own mother had a disc herniation in her lower back. My mother, I'm the firstborn son. Me and my mother were very close. She saw how hard I worked, how many hours I spent training and studying. And she had a disc herniation in her back. And the pain was radiating down the L4 distribution. So that would be the front of her knee to the front of her shin. And I said, Mom, I think this is coming from your back. And my own mom was like, no, it's my leg. It's not my back. She didn't believe me. And it's referred, when you have a pinched nerve in your back, it can refer to your leg. Most of the problems from a nerve compression will result in leg pain, not back pain. And my own mother did not believe me. So I can understand some of the skepticism when people come in and say, I have leg pain, not back pain. But it's the nerves in your back that supply your legs. And if those nerves are compressed, you have severe pain in your legs, an operation does excellent to remove that pressure and improve your ability to walk, prevent permanent damage to the nerves in your back. So this is an example of an MRI, a lumbar MRI. This is looking at someone from the side. On the right, my right, is a normal MRI. And you can see the discs are all well hydrated. The disc spaces are symmetric. The spinal canal is open. Here on my left is a disc herniation at the L5-S1 level. There's a big protrusion. It's pinching the nerve. This is a patient that presented with severe pain shooting down the back of the leg, pain in the S1 distribution, butt, back of the thigh, calf to the lateral border of the foot, had weakness in their calf muscle, which is what the nerve that innervates the calf is S1. And so they had weakness and pain in the S1 distribution. This is when we consider an operation. So this is a cross-sectional view. This is looking at somebody from the top down. And this illustrates kind of, what a disc herniation does. It results in compression of the nerve in the back. The nerve is pinched, causes pain, numbness, weakness down the leg. And so this is a large disc herniation, which is narrowing the space from the nerves. Instead of this being a nice open circle, you can see this big disc protrusion. And when that nerve is pinched, it causes leg pain. So if someone comes in with compression like this, pain, numbness, or weakness in the nerve, which is compressed, this is a slam dunk home run. They'll have an operation and do very well. Now, everyone that has a disc herniation does not need surgery. And most commonly, we can treat these patients without an operation, even patients who have leg pain. So if someone has compression of a nerve and has a disc herniation, very commonly we'll send them for injections and physical therapy. And that is effective at treating the problem 60 to 70% of the time. Patients who have persistent leg pain or weakness, that's when we consider doing an operation if they fail conservative management. The goal is to get people better, not just to do surgery. And the vast majority of the time, we can get people through these circumstances without an operation. We have excellent non-operative providers at Rothman Institute who can provide injections, do physical therapy, and very commonly, we're guiding people down that path. What is concerning is patients who develop weakness. So if you start losing the ability to walk or have severe weakness in your leg or severe leg pain, surgery very quickly alleviates that problem. What surgery does not fix, and what I commonly see, is someone who comes in with a disc herniation and has back pain, no leg pain, but isolated back pain. Removing that disc is unlikely to improve their back pain. And so even in the presence of a disc herniation, if there is an absence of pain or weakness in the distribution of the nerve that is compressed, very commonly we are recommending against any surgical intervention because removing that disc is unlikely to improve the pain in the back. Back pain is typically improved with physical therapy, methods to strengthen the muscles which support the spine. Cauda equina syndrome is a very serious circumstance in which there is a very big disc herniation or a mass or a trauma, something that is compressing the nerves in the back very severely, so severely that it can result in the nerves that supply the bowel and bladder to stop working. And so if you have incontinence, the bowel or bladder, numbness in your groin, Cauda equina syndrome is something that we as surgeons think about. It is not common. It is very rare. It is not an intermittent thing. So I have a lot of people who come in and say, oh, I'm incontinent. I can't make it to the bathroom, because they can't get to the bathroom in time because of other issues, or they have intermittent bouts of incontinence. That's not reflective of Cauda equina. Cauda equina is a light switch. So meaning the nerves are pinched, they're being choked to death. You lose bowel and bladder function. That does not come and go. Once it's out, it is out. If you lose the ability to control your bowel and bladder function, and you have an MRI which shows severe stenosis, that is a real concern. And that's something which is typically treated emergently with an operation to remove pressure from the nerves. The goal and the hope is that those nerves can recover. Unfortunately, we don't have the ability to fix nerves. And so if you're in a situation where you lose this function, time is of the essence. And really the analogy is, if a baby falls in the pool, you want to get that baby out of the pool as quickly as possible, because they can only hold their breath for so long. And if you do not get that child out in time, obviously it's a terrible situation. And that's the same circumstance with the nerves in your back. Your nerves are compressed to a point where they can't breathe and the blood supply is blocked or interrupted. If you don't remove that pressure quickly, it can be a permanent situation. And so people who have incontinence to bowel or bladder, numbness in their groin, this is an emergent situation. And I can tell you it's pretty rare, but it is something to be cognizant of, because the nerves in your back supply your bowel and bladder function. If you lose that, that is what Cauda equina syndrome is. I very commonly get calls and questions about this. This is not an intermittent thing. When it is out, it is out. It's progressive, and it is not something that, can wait. It needs to be treated emergently. In the absence of this, most of the issues in the lumbar spine can be treated in an elective fashion. So let's look at a couple MRIs and some examples of some disc herniation. So you hear people say, oh, I have a disc bulge, I have a disc herniation, and I have an extruded disc. What does that mean? So there's a lot of semantics in describing what a disc herniation is. Remember, the disc is like a jelly donut or a tire. There's an outer ring and there's an inner jelly. And so an annular bulge would imply that the outer ring is still intact, but there is a protrusion of that ring into the spinal canal. So what you can see is this big bulge here. This is a bulge. So that annulus, the outer ring, is still intact, but it is encroaching upon the space for the nerves. A disc extrusion would imply that the inner jelly has pushed through the annular ring. So that outer ring has popped, just like a busted tire on a car, and the jelly is squirted into the spinal canal and is now compressing nerves. And so this is an example of a disc extrusion. So what you see in green is this central circle is called the thecal sac. This is what holds the nerves. These green dots on either side of the nerve roots, which are exiting the spinal column. And this is an extruded disc fragment. So that red that's a piece of disc which got shot off into the spinal canal. Extruded disc fragments have an ability to be resorbed by the body. There is a very robust vascular plexus around the nerves. And so the extruded fragments are the ones that typically can be resorbed. In the absence of severe weakness, we typically try to treat these patients conservatively. If they have severe pain, we remove the herniation, and typically the pain gets better. But I get a lot of questions about an annular bulge versus a herniation versus an extruded disc. A lot of it is semantics. The bottom line is, if a nerve is compressed, it can cause pain in the leg. A bulge would imply that the disc is still intact, but it's like a bubble on a tire. An extruded herniation would mean that the tire has burst and the jelly that's inside is squirted into the spinal canal. So this is an example of a broad-based disc herniation, which is narrowing the space for the nerves. So what you see Here, this green circle shows the thecal sac, the space for the nerves. The white is the lubricating fluid. These little dots are the nerve roots. And the squares on either side are actually the nerve roots exiting the spinal column on each side. And what you can see here on my right is a broad-based disc. This is a herniation disc or a bulge. The annulus is still intact, but it's narrowing the space for the nerves. And this person presented with some leg pain, some difficulty walking. We treated them with injections, and they ultimately did get better, didn't require surgery. If you see this herniation, it definitely narrows the space, but there's still some space present. You can still see some white fluid, you can still see some nerves, and oftentimes these patients can be treated without an operation. This is an example of a very severe disc herniation. So this MRI on my left is the MRI looking from the side, and the yellow lines kind of shows the cross section of where we're looking at on the right. So you can see that the space for the nerves is open. And then when we go down to the level which is compressed, there's a massive disc herniation here. There is no space for those nerves. Those nerves are very severely compressed. This person presented with severe leg pain, numbness in their groin. This is a Cauda equina circumstance where you're really concerned about the health of the nerves. So that pressure needs to be removed. So just to kind of reiterate the point, if you look here on my right, you can see the space for the nerves. This is at the L4-5 level. This is what it should look like. And when we go down to 5-1, there's a huge herniation, severe compression of the nerves. Person presented with leg pain, weakness, numbness in their groin. That is a disc herniation that needs to be removed. And this is not one in which we would consider doing injections or conservative treatment. Most of the time, we have the ability to do or remove these discs in a very minimally invasive manner. Spine surgery has evolved to a point that we do mostly muscle sparing approaches. You hear a lot of people ask questions about laser. Do you use lasers, or do you use a camera? And the reality of the situation is a lot of that is marketing. You see laser spine and you see someone with a little Band-Aid on their back. And the fact of the matter is there's no real proven benefit to using a laser in the operation. It sounds like a laser is really cool, but the fact of the matter is the goal of these surgeries are to remove whatever is pinching your nerve. That's what spine surgery does. Nerve is pinched, you remove the pressure. And our goal is to do that in the least invasive manner as possible. And now we have the ability to do that through muscle sparing approaches, very small incisions. We don't have to cut muscles, spread them out of the way, make small windows in the bone, remove the disc herniation. So this is an example of a patient who had a very large disc herniation. You can see the size of the incision here in surgery. This to the right is the fragment that was removed. So that was the portion of the disc which was extruded from the disc, pinching the nerve. I pulled that herniation out. Patient wakes up, leg pain's better. They go home same day, typically the same day. So what is spinal stenosis? So spinal stenosis is a question that I get very, very commonly, and it's a pretty broad-based term, just kind of like sciatica. When someone says, I got sciatica, I have many people come in and say, I have sciatica, my back hurts. That's not really sciatica. Sciatica would imply a nerve is pinched in your back, and that's going to cause pain in your leg. Stenosis is another one of those terms which you hear is thrown around. And the question is, what really is it? What is stenosis? Stenosis is simple. It means that the space for the nerves in your back has been compromised. So instead of having an open epidural space, the nerves in your back are encroached upon or pinched. And there are a number of reasons why that can happen. You can have spinal stenosis as a result of a big disc herniation, which is narrowing the space. And I showed some examples of that. You can have spinal stenosis because you've developed arthritis. So the disc has degenerated, the bones are bumping together. Arthritis or bone spurs has started to encroach upon the space and pinch the nerves. You can have spinal stenosis because you have a deformity or a big curve in your back or a slippage of the vertebrae. So there's many reasons why you can have stenosis. But the point of the matter is stenosis essentially implies the space for the nerves has been compromised and is being compressed. And so this is just kind of a graphical representation of that, of a normal anatomy on the left. So you can see the disc in the front. the epidural space with the nerve roots. The lamina is the bone that protects the nerves in the back and the facet joints. And so if you develop arthritis of those joints, that can start to impede or encroach upon the space for the nerves. So that, you can develop arthritis, which is posterior. You can have a disc herniation, which is coming from the front. All of these things do the same thing. Compress nerves, narrow the space for the nerves in your spinal canal. That is essentially what spinal stenosis is. One of the classic things that occurs with spinal stenosis, and one of the textbook findings of spinal stenosis, is that when you walk, you develop pain that shoots down your leg. When you sit down, the pain gets better, but you can't walk if you lean forward. And the reason leaning forward allows you to walk is that it opens up your spinal canal. It provides some space for the nerves so the nerves can breathe. So our body, our minds are very intelligent, even intuitively. And one of the compensation mechanisms is leaning forward. Leaning forward opens up the space for the nerves so the nerves can breathe. And so what you see is people with severe stenosis often walk leaned over a shopping cart or walk with a cane. And when you walk with a bent over leaning forward, it opens up the space for the nerves and makes it easier for you to walk. So that's a classic kind of example or presentation of spinal stenosis. And this is just another MRI representation where you can see this patient. This is looking at it from the side. The furthest image on the left, the bones have slipped or translated, and there's some narrowing of the space for the nerves here. And if you look in cross section, a normal cross section should look like a circle. The epidural space should be wide open. Stenosis, now it looks like a triangle. Those nerves are compressed, and that's because of arthropathy of the facet joints, or arthritis of these joints here is narrowing the space for the spinal canal. So that's spinal stenosis. And this is just kind of another representation of that. And this white is the lubricating fluid. These little dots are the nerve roots. This should look like a nice clock face or a big open circle. And it looks like a triangle. And it looks like a triangle because these joints have become arthritic. The reason they're arthritic is the disc degenerated, the bones are bumping together, and now it is narrowing the space for the nerves. This causes pain shooting down the legs, difficulty walking any prolonged distances. This is classic spinal stenosis. And so if you look at this, this is, again, just another representation of that. A picture is worth 1,000 words. You can see this big open space, this circle, these little dots are the nerve roots. The white is the lubricating fluid. And if you look at on the right side, it's gone. The nerves are compressed very severely. This is a patient that presented with severe pain radiating down their legs, had a difficulty walking any prolonged distances. This is very, very severe stenosis. And so what we do to treat stenosis is to open up that space. So a laminectomy is an operation where you remove this wishbone structure, you remove part of the joints to open up the space so the nerves can breathe. Removing pressure from nerves typically alleviates leg pain and improves ability to walk. And this is the whole premise of spinal surgery in your lower back. So we talked about neurologic compression. Why do you have spine surgery? If nerves are pinched, you will have pain in your legs. Pain radiating down your legs is because those nerves are pinched, they can't breathe, you remove the pressure. If the bones are translated or slipped in your back, that can cause severe back pain, that can result in compression of nerves. That's when we consider an operation. And so this is an example of a translated or slipped vertebrae here. You look at this vertebrae here, the back of this bone should be all the way here, but that bone has translated or slipped. That's called a spondylolisthesis. Like driving a car with the loose lug nuts on the tire. You hit the gas, the tire is flopping around. This is a mechanical issue. When bones are slipping and there's instability, we consider doing operations to stabilize these bones. And so this is when we would consider a fusion operation to stabilize the bones so that they're not slipping back and forth. And there's a lot of stigma of fusion. People say, I don't want a fusion. If you break your arm, they either put you in a cast or they put rods and screws in the bone to stabilize it. A fusion is essentially an internal cast or brace to hold the bones together so they're not slipping. That provides a stable base. The bones heal together. It protects your nerves. So this is an example of a spondylolisthesis. So this patient has a translation or a slippage of the L4 on the L5 vertebrae. As a result, It results in compression of the nerves in the back. So you can see the white fluid is being occluded. This looks like an hourglass, and you can see it's being pinched here. So the patient has spinal stenosis as a result of a slip vertebrae or spondylolisthesis. I see this many times every week. This is a very common reason to require an operation that opens up the space for the nerves, stabilizes the bones. If this person presents with leg pain, difficulty walking, an operation will help them tremendously. This is just a graphical representation of that. These red boxes represent the vertebrae. The back of these boxes should be aligned. And you can see here, there's a translation of the vertebrae. And then the MRI on the right shows the nerves are pinched as a result of that slippage. This is a very good reason to have an operation. People do very well. And how we treat it is with rods and screws. So these rods and screws serve as a brace or a cast, pulls the bones back in position, remove the pressure from the nerves, improves leg pain, ability to walk, prevents nerve damage. Another thing that can happen when the bones are translated or slip is you can develop cysts. And I very commonly see patients come in with cysts in their back, and that's because the bones are shucking and jiving back and forth. Cysts develop. The cyst can also encroach upon the space for the nerve. So you can see this cyst here. Instead of the fecal sac being wide open, it's being pinched. So this young lady had severe leg pain. This is not cancerous. People all the time say, oh, I got this cyst in my back, is it cancerous? No, this is a mechanical issue. The bones are slipping. The cyst has developed, and as a result, it's pinching the nerve. This is a mechanical problem. Bones slipping back and forth. Remove the pressure from the nerves, stabilize the bones, substantially improves leg pain, ability to walk. And so this arrow kind of illustrates that cyst there. This is another example of a slippage of the bones. So this is called an isthmic spondylolisthesis, which is a fancy medical term, but essentially what it means is that the pars intraarticularis, or the portion of the bones that connects the vertebral segments together right here, did not fuse. So in your development, when you were growing, those bones didn't fuse. This very commonly happens at L5S1, so there's a defect here. So as a result, the disc collapsed, the bones slip together, the nerve gets pinched. So if you look here, this green arrow is pointing to the disc space. You can see how open this disc space is. This green circle is the neuroforamen. That's where the nerve root that supplies your legs is exiting. So that's the L4 neuroforamen, and you can see how big that nerve root is, how big that hole is. Here, this arrow in the front shows that disc is collapsed. So if you look at the disc, the difference in the disc height here, the disc is collapsed. The reason it's collapsed is because there's a pars defect, so that these bones haven't fused, and so there's a slippage. And look at the difference in the size of the foramen. That foramen is being squashed. So that bone is slipped forward, the nerve is pinched. This guy presented with severe back pain, severe leg pain, and this is a mechanical issue. Bone slipped, nerves pinched, pain shooting down the leg, and so this is something we can fix. The MRI shows that nerve root compression. So if you look at this MRI here from the side, this is the belly here, this is the back. You can see the spinal canal itself is open. The problem is the nerve root is being pinched. So this is the L4 nerve root, this dot right here. You can see how big this hole is. And if you look below, this is the nerve right here, which is being pinched very severely. You can see the nerve, that nerve is being pinched, and that's because those bones have slipped. This will result in severe leg pain, inability to walk. So this is the before and after. So this is an operation to open up the space for the nerve. So we placed the cage that opened up the foramen, or the space for the nerves. The rods and the screws serve as the brace. This guy was a bodybuilder, so was very active and got back to working out, at a very high level. An operation like this does not preclude you from doing physical function. We do these surgeries to preserve function. If nerves are pinched and your nerves are damaged, that's what prevents you from walking and doing things that you want to do. And so when we stabilize the bones, remove pressure from the nerves, this puts you in a position to get better. And so the operation is one piece of the puzzle. Physical therapy, strengthening a healthy lifestyle is critically important for you to reach your ceiling, to be active. The surgery won't do that for you, but it will remove pressure and give you the opportunity to do the things that you want to do. And so this is a prime example of that. Another reason I commonly do surgery, unfortunately, is because of fracture. You know, Atlantic City, very commonly, I see severe injuries from motor vehicle accidents, people falling off of high distances, and there's a whole spectrum of fractures. So this is an example of a fracture of the transverse process. So this is a CT scan which shows bone. This little finger-like thing is the transverse process. And there are muscular attachments to this, but a transverse process fracture does not compromise the stability of your spine. So if this is broken, it will hurt. It doesn't need surgery. It's treated with physical therapy. It will heal. Compression fractures. Compression fractures are something we very commonly see, particularly in postmenopausal women. As women get older, go through menopause, their bodies no longer make estrogen. Estrogen is a hormone that protects your bones. When you don't make estrogen, your bones start to hollow or shell out. Your bone is a very active and alive organ, just like your heart, your lungs. Your bone is essentially an organ. And so your body is constantly building and breaking down bone. And so as you age, what happens is for people who develop osteoporosis, the bones break down quicker than they form. That results in the bones shelling out or becoming very hollow and soft, almost like an eggshell, and can result in compression fractures or collapse of the bones in the back. And this can happen from very minor traumas to just sneezing, to sitting down on a chair. These are also not fractures which are treated typically with surgery. These are typically fractures which are treated medically. So giving you medications to strengthen your bones, and to do physical therapy to strengthen the muscles that support your spine. The fractures that typically do need surgery are fractures that result in instability of the spinal column. So if the spinal column is broken or fractured, and as a result, there's compression of nerves. So this is a burst fracture in which the bone is burst apart. It's pinching nerves in the back. This person needs an operation, and the whole purpose of these surgeries are to remove pressure from the nerves, stabilize the spinal column, hope and pray, for the best outcome. We don't have the ability to fix damaged nerves. Removing pressure, stabilizing the spinal column gives folks a chance to improve. But these are the circumstances in which we do have to do surgery, and unfortunately, we have to do it relatively commonly. Motor vehicle accidents, falls from substantial heights. These are typically injuries that occur from a substantial mechanism. The worst of which is when there's translation of the spinal column, which certainly can occur. And this is just an example of that. It's the guy who fell, was working, fell 20, 30 feet and translated his spinal column. Obviously, this needs to be treated surgically. What I have the ability to do is realign and stabilize the bones. I do not have the ability to fix the nerves. Removing pressure from the nerves allows the nerves to heal. Depending upon the damage of the nerves at the time of injury really determines the outcome. And so operations for trauma are really designed to stabilize the spinal column and kind of create an environment which hopefully the nerves can recover. So this is a woman who I treated. She had an L3 burst fracture. She was in a motor vehicle accident, which was quite substantial. You can see that this bone, the L3 vertebrae, is cracked in half. As a result, bone is in her spinal canal. She presented not only with severe back pain, with substantial weakness of her legs. She couldn't stand. She had a hard time moving her legs. And her MRI shows that her nerves are pinched quite severely in her back. So she needed an operation in which I removed the pressure from the nerves. I did that by removing the entire broken bone. That's this cage here, and then placing rods and screws in her back. And thank God she did regain some function over time, had the ability to walk. Obviously, her spine is not the same, but we were able to get her back to at least a functional and a reasonable place. Another reason that we do consider surgery at times is for deformity. So people who have scoliotic curves. And so this is an example of a scoliosis or a curve to the spine. And oftentimes we see people, we're very fixated on looking at them from the front and seeing that big curve. But what really matters is our ability to stand upright. So to have your butt and your head in a line. So your head is over top of your butt. And the reason your head is over top of your butt is because of the normal curvature of your spine. There is kyphosis in your thoracic spine and lordosis in your lumbar spine. Fancy medical terms for just meaning there's curves in your back. Your head is over your butt. And what happens is when you develop arthritis, degeneration of the disc, your spine straightens out, which results in you leaning forward. And so there are mechanisms that our body has by what's called retroverting your pelvis to try to get you up and standing upright, but that's a very difficult way to walk. And so this is an example of a patient who had a very straight spine. So he lost his normal curvature of his back. He does have a curve in the front, but the curve in the front is not so much the issue. It's the problem that he's lost the normal alignment of his back. And so in order for him to stand upright, he has to bend his knees, bend his pelvis. In addition, he has a lot of stenosis or compression of the nerves in his back. Those nerves are pinched. And so he can only walk very short distances and he can't stand upright. And so the circle shows that that space where the nerves should be open is compressed. It's being compressed for two reasons: arthritis of his joints and then a large disc herniation. And so I did an operation to realign his bones, remove pressure from his nerves. This is an extreme example of someone who had a very severe deformity and was able to do a very large surgery to realign the nerves in his back. This is not, we obviously have the capability of doing this. This is a rare circumstance. And typically, most people can be treated with much, much smaller surgeries. Many people who have scoliosis are not treated with an operation. And in order to do a surgery like this, it takes, a lot of coordination with the medical doctors to make sure that the people are optimized from a medical standpoint, have adequate nutrition. And so these are the cool things that we have the ability to do. But as a spinal surgeon, I love to do this because this is what I trained to do. But as a human being, I have parents, I have, people, my parents are in their 70s. And so I think about, would I want my parent to have this operation? And so oftentimes I dissuade people from these surgeries. In order for me to do something like this, it has to make a lot of sense. It has to be, the risk has to outweigh the benefit. And so there are many people who come in with scoliotic curves that I tell them they need to do aquatherapy, they need to do nutrition, injections, they don't need this surgery. And so this is not something, an undertaking that we do just to do. It has to make sense for us to do something like this. And so this was a particular circumstance where this guy could not stand upright, terrible stenosis. He had this very massive operation and it substantially improved his quality of life and his ability to walk. And that's ultimately what we're concerned about. Surgery or not, is putting you in the best position to maximize what you have. That doesn't mean it's going to be perfect, but to maximize what you do have. Sometimes that requires surgery, sometimes not. Back pain, see it all the time. Everyone has back pain, everyone. And very commonly, I see people who have disc degeneration like this. So if you look at this MRI, these are normal healthy discs. You can see the white fluid within the disc. At the base of their spine, these discs are dark. This is someone who does not have stenosis, no compression on the nerves in their back, disc degeneration, severe back pain. Very controversial to do surgery in this circumstance. The reason you do surgery: nerve root compression, instability, deformity. Back pain surgery for disc degeneration, very controversial. These are the patients that typically say, I had surgery and got worse. And so I am incredibly hesitant to do an operation on somebody who has purely back pain and disc degeneration in the absence of any neurologic compression. If they have instability and back pain, certainly something that we consider more frequently than just pure axial back pain and disc degeneration. That is not a good reason to have surgery. There's not a quick fix for that, but typically injections and therapy is the way that is treated. Occasionally, I do have to do an operation for infection. If you develop an infection in your spinal canal, certainly that is something which is treated surgically to evacuate that abscess. That's not something that happens very commonly in most normal folks, but it can happen, particularly in people who are diabetics, which is poorly controlled. You can see infections which develop. So quickly to touch upon the cervical spine, just hit you with a lot of information about lumbar spine. Cervical spine is pretty similar in that nerves in your neck supply your arm. So a pinched nerve in your neck is going to cause pain shooting down your arm. So this is a young person who came to see me, has a normal x-ray of their neck, not much arthritis. Their disc spaces are all symmetric. Had a very big disc herniation here on the right side, which was pinching the C7 nerve root. Compression of the C7 nerve root is going to cause pain shooting down the arm. He had substantial weakness in the triceps. He couldn't do a push-up. So this is a person who had a total disc arthroplasty. So I removed the diseased disc, removed the pressure from the nerves, and placed an artificial disc. So this is a motion preservation surgery. Don't feel it. The operation essentially removes the pressure from the nerves. Arm pain, weakness improved. They don't lose any motion in their neck. This is a little bit of a different circumstance. This is a person who has some disc degeneration at this is C3, C4, C5, C6. This disc is degenerated. You can see some bird beaking here. So there is arthritis at this segment. The MRI shows that the spinal cord is compressed. So there's a disc herniation, there's arthritis, spinal cord is compressed. This person needs a fusion. You do not do a disc replacement on an arthritic segment. That's like replacing a tire on it and the rim is bent. If the rim is bent, you got to replace the whole thing. So this is a fusion. So what are the implications of fusion? If you fuse a segment in the neck, it's not going to necessarily affect motion. The concern is development of arthritis above or below. And that can happen in about 1 in 5 people at 10 years. And that's a real concern. But a disc replacement in this circumstance is not appropriate. This person needed a decompression infusion to stabilize that level. That's an arthritic segment that needed to be stabilized. These operations go very well. People do incredibly well from anterior cervical discectomy procedures, infusions, if necessary. Again, this is something which is only done if it is necessary, but the whole purpose is to remove pressure from the spinal cord. This is an MRI showing compression of the spinal cord. If the spinal cord is compressed, that is the information highway between your brain and your body. How that presents is issues with balance, strength, and dexterity. So this is a person who has substantial spinal cord compression. You can see down here at the bottom, the spinal cord is freely floating in the fluid. Here, that spinal cord is pinched. This person presented with ambulatory dysfunction. They were tripping and falling. They were dropping objects. They had an operation to remove the pressure from their spinal cord. These surgeries do not fix the spinal cord, but removing the pressure allows the spinal cord to breathe, hopefully to heal. And so most people regain some function, but the whole proponent is to prevent people from getting worse. And so this is an example of an operation to remove pressure from the spinal cord so it can breathe. This can be done in fusion and in non-fusion options depending upon the patient. And so a laminoplasty is an operation that we do occasionally, open up the space for the nerve so that the nerve or the spinal cord can breathe. So this plate shows kind of a hinging open of the space for the nerves. And so if you look at this here, this thing is the spinal cord here. This is the lamina, which has been hinged open to open up the space for the spinal cord. And so occasionally in patients who have normal alignment, not a lot of arthritis, we can do these non-fusion procedures. This is an example of someone who had a fusion versus not a fusion. The goals are the same: remove pressure from the spinal cord. If it can be done without a fusion, we certainly do it, and no one is more capable of doing that than the spine surgeons at Rothman Institute. If you need a fusion and your surgeon tells you you need a fusion, it's probably for a reason. And if the bones are very arthritic, there's not normal alignment of the spine, then sometimes a fusion is required. I can assure you we don't do it unless it is indicated and is needed to meet the ultimate goal, which is to protect your spinal cord or nerve roots. Just like trauma in the neck or in the lower back, we see fractures in the neck. So, you know, one of the very humbling things about being a spinal surgeon is spinal cord injuries, because unfortunately, we do not have the ability to fix the spinal cord. What we can do is remove pressure from the spinal cord. Then we hope and pray that the spinal cord returns, the function returns. So this is a gentleman of mine. He had a fractured dislocation of his neck. He presented with a substantial spinal cord injury, couldn't move his arms or his legs. I took him to surgery, realigned his spinal column from the front and from the back. And thank God he was able to regain substantial function, able to ultimately walk this is an incredible, miraculous recovery. This is not because of me. This is because of God. The only thing I did was realign the bones in his neck. And obviously he was grateful to me, but this was not a result of me. The spinal cord healed. There was a confluence of factors that getting to him quickly, removing pressure off of his spinal cord. But we don't have the ability to fix the spinal cord if it's damaged. Only thing we can do is realign the bones and hope and pray. Occasionally it does work out. And in those circumstances, we say our prayers. But spinal cord injury is a very humbling thing. So this is just kind of of him. So these are very humbling cases because obviously was able to help him. And this is ultimately the reason you become a spinal surgeon is to help somebody, is to help people. People come in the most dire of circumstances, severe pain, weakness, inability to walk. Spinal cord injury is the combination of that because it happens so quickly. And if you get to people quickly, sometimes you can reverse their course. And this was a very lucky circumstance in which we were able to do that. So some of the advances in spinal surgery, just going to touch upon this quickly. And wrap up this lecture. So multimodal analgesic protocol, MMA, means we can do surgery without the need to give substantial opioid narcotics. Opioids are required sometimes after surgery, but the goal is to limit the requirement of opioids after surgery. And so we have protocols in which we give patients a number of medications to limit their pain after surgery, and that hastens recovery. When I was training, we do lumbar fusions on people when they be in the hospital for a week. Most of the time, when I do a lumbar fusion, patients are in the hospital for 1 or 2 days. We have the ability to substantially limit blood loss, and that is from some of the medications we give, the surgical techniques we use, and also the development of minimally invasive surgery. This was a study I did years ago looking at how we can limit allogenic transfusions, which mean blood from a bank. We recycle your own blood in surgery. We can give you medications which limit your blood loss in surgery called tranexamic acid. We have certain tools in surgery called the aquamanus, which really limit bleeding. And the cell saver is literally when we recycle your own blood. So whatever blood is lost is given back to you. Minimally invasive surgery would mean that we very rarely have to do these big open approaches to access your spine. We can do most of the operations through very small incisions, which are muscle sparing, and that limits soft tissue dissection, limits the amount of time that you have to lay in bed. Most people can get up pretty quickly after these operations, and we have the ability to do a lot of things through very small incisions. So I hope this answers some of the questions about spinal surgery. I know there's a lot of fear and concern about it. If you have some issues, obviously we're happy to evaluate you to determine if you need an operation. Our goal is not to do surgery. The goal is to get you better. And if that requires an operation, we'll do it. If it doesn't, we'll send you to the non-operative providers. The key for you is to get the information. Once you get the information, you can make the informed decision. So if there's any questions, I'm happy to try to address those. This is the number for Rothman Institute to make an appointment. This is my email address, and thank you all for your time.
Dr. Woods, thank you. So much valuable information. I know everyone has submitted so many questions, so we are going to get to as many as we possibly can. And if your question doesn't get answered, Dr. Woods and I will review the questions at another time, and we will try to respond to you via email. So hopefully that helps as well. So one of the questions that came in, and we're going to jump around a little bit here because they're not consistent with any topic. Is it better to start with a medical branch block ablation prior to considering surgery?
So that's a very broad question and one that's hard to answer. A medical block ablation essentially is a procedure which is done to numb the joints that are in your back. So if you have someone that has arthritis in their knees or their hips, very commonly you see, particularly knees, they're getting steroid injections in their knees. And steroid injections are done to decrease inflammation and to prolong or prevent them from needing a knee replacement. When you have arthritis in your back, that can cause back pain. Arthritis in the back is typically in the facet joints. And if those facet joints become arthritic, we can do facet injections. If you have back pain and have a facet injection, which substantially improves your pain, but it only lasts for a short period of time, then a medial branch block ablation can be performed. And that is essentially where they numb or burn the joints in your back to numb it more permanently to turn off the pain. Back pain in and of itself is typically not a reason to have surgery. If you have severe arthritis and you have back pain and you get a facet injection and your back pain improves, and you get a branch ablation and your back pain improves, but it returns, that is the circumstance. If you have severe arthritis, we may consider surgery. If you have a facet injection or a medial branch block ablation that doesn't really help you, putting rods and screws in your back is not going to help you either. And so, you know, that's a circumstance where really you have to look on an individual basis. Certainly, if you have back pain and arthritis, we would send you for a branch block ablation before considering doing an operation. And an operation would only be considered if you responded to the treatment, but it just didn't last.
Thank you, Dr. Woods. Are there side effects to a laminectomy?
So a laminectomy implies that there's removal of bone from your back. The bone that is removed is not critical to the structural integrity of your spine. So removing the pressure off your nerves by opening up the space with a laminectomy, there's not really side effects to that. The side effects are from the arthritis that has developed. The disc has degenerated. The laminectomy is done to open up the space for the nerves, but it doesn't fix the underlying problem in that there's still degeneration of the disc. So if you don't fuse that segment, over time, you could develop arthritis again. So the issue is not so much with the laminectomy. The laminectomy is done to open up space for the nerves. The issue is with the disc and the arthritis that is developed. That arthritis can be removed, but it can recur if you don't fuse that segment. Very commonly, we just do laminectomies and don't fuse patients. You know, most people do not develop recurrent arthritis. Some people do. Those are the patients that need more surgery occasionally. You're muted.
Sorry about that. I apologize. Is there any danger in delaying surgery, assuming you have some relief from steroid injections? No weakness, pain?
That's a great question. No. Unless there is severe spinal cord compression in your neck, people that typically have spinal cord compression, we recommend surgery, and we typically do it aggressively because if your spinal cord is compressed and Lord forbid you're in some type of accident, it increases your likelihood of some type of traumatic injury or permanent neurological deficit. If you have lumbar spine issues, the injections help you, and you don't have any progressive weakness, then certainly injections can be done for years. And if if there's not weakness and the injections are effective, you continue to do that until they're no longer effective. What becomes concerning is if you start developing weakness, in your legs and inability to walk, or the injections aren't helping anymore, that's when we do an operation. But in the absence of weakness, if the injections are effective, then no, there's not a problem. The issue is if you get an injection and it only lasts 2 days, you can't get an injection every 2 or 3 days. Most of the time you can get an injection every, on average 2 to 3 months. So if you are getting injections that are giving you several weeks of improvement, then there's not a harm in delaying an operation as long as there is some response to the injections and you don't have weakness.
Awesome, thank you. If you have a bulge and do not need surgery, if you have a bulge and do not need surgery, is the pain resolved after conservative treatment? Would you tell patients to be careful in movement?
No, so a disc bulge in and of itself is not going to result in instability or stabilize your spinal column. But if you have arthritis as you get older, you got to be smart. Even myself, every day I get out of the bed in the morning and I'm stiff. And maybe that's my kids, they're running me around. I feel like I'm getting old. But as you have to be wise. You have to use proper ergonomic techniques when you're doing things. But a disc bulge doesn't preclude you from living life and doing normal things. But you got to use some wisdom. You got to be smart about the position that you put your body in.
Good answer. What is the difference between a laparoscopic versus endoscopic discectomy? Do you do both, and which do you feel is superior, and why, or safer?
So that's a good question. So laparoscopic means that there's a camera, or endoscopic These are terms that means that you use a camera to do the decompression. A discectomy, when you do a discectomy, the purpose of the discectomy is to remove the pressure from the nerve. And there's a lot of ways to do that. We do minimally invasive discectomies, which do not use cameras, but essentially are muscle sparing. You don't have to compress it or don't have to cut any muscles, you spread them out the way. There's not superiority. The whole goal is to remove pressure. So it's not like using a camera makes it superior to not using a camera. Removing the pressure from the nerve is what makes you better. And the goal is to do that in the least invasive fashion. And we can do that without cameras. I do discectomies every week. People go home the same day. And the whole purpose of the operation is get the pressure off your nerve. And that can be done very safely in a number of ways. It does not require a camera. No.
Great, thank you. Are there any treatments for spinal stenosis other than surgery?
Many. The foundational treatment is therapy. Therapy improves and strengthens the muscles that support your spine. There's no shortcut to that. The foundational treatment is doing exercises which improve blood flow and strengthen the muscles that surround your spine. In conjunction to that, anti-inflammatory medications, anti-neuropathic medications such as gabapentin, which protect the nerves, can be given. Injections which decrease inflammation can be given. Really depends upon the symptoms. Yes, most patients that have spinal stenosis don't have surgery. Surgery is done for patients with spinal stenosis who have severe leg pain that is precluding their ability to walk despite having tried conservative treatment. So most of the time, patients with spinal stenosis are treated with injections and physical therapy, medications, as an alternative to surgery. If the leg pain becomes severe, they start losing the ability to walk. That's when we consider doing an operation.
That's great. How old can you be to have a fusion or a cage? Is 81 too old? Healthy and active? Please comment on recovery time.
That's a great question. Age is nothing but a number. I can tell you, I see patients who are 45 that look like they're 90. I see patients that are 90 that look like they're 60. And so, everyone gets an individualized treatment. When I see somebody, and my colleagues evaluate you at the Rothman Institute, if it's myself or somebody else, we're going to look at you as a person, not as a number. The question is, what is your problem and how is it affecting you and how can we help you? If that requires a fusion and that's what you need, 81 years old will not preclude you from that. I've done fusions on people in their 90s, but that was a very thoughtful approach. And we're thinking about the totality of the situation, kind of what your baseline level of function is, your health level, your age is one factor in that. And so age in of itself is not a number that would, preclude you from any treatment. There's a number of variables that go into that decision-making process. And that's why we sit down, we talk. We don't just look at your imaging studies. We talk to you first, determine what the issue is, and then determine what the best treatment for you is as a person. But your age is not what typically is the limiting factor.
Thank you, Dr. Woods. I just want to say thank you for everyone to joining us tonight. So much valuable information. Please know that this webinar is recorded and it will be sent to you in an email within about 7 business days. So we just want to thank you for your time. We don't want to take too much of your time in this evening. It is a little past 7 already. So Dr. Woods, thank you. Thank you. I learn something every time when I listen to you. So I hope everyone enjoyed the webinar. If you have any questions, please call Rothman at the 1-800 number, or feel free to email Dr. Woods or myself, melanie.ionase@rothmanortho.com, and we will definitely get back to you with some type of answer to help you along your journey.
Thank you. God bless.
Thanks, Dr. Woods.